Good morning and welcome everyone to part 3 of our MDS 3.0 updates and long-term care changes training. I'm Carol Eastburg, the REI MDS and OASIS Education Coordinator for the state of Nevada, going on 10 years now. And prior to this position, I was on the survey team and participated in on-site state licensure, federal recertification surveys, and complaint investigations for several facility types. In the email I sent a few minutes ago, you should have received the slides along with a couple of other documents I'll be talking about today. And also included was a link to the final version of the REI user manual. Please have that handy as we go through the slides. I'll be referring to certain pages in it, and I would like for you to be able to see what I'm talking about. Obviously, it's way too much to have on the slides, or for me to explain. All right, our agenda today doesn't include an official break as usual, so take one as needed, but please hurry back because we miss you when you're gone and we don't want you to miss anything. I'll be picking up from where we ended on July 19th, right after I address a few questions submitted by attendees after that training. After today's session, attendees will be familiar with changes to the item sets, understand how to properly code all the items that we discuss, and be equipped with resources and know where to find information you need while on the job between these trainings. By the way, when CMS announced the final version of the REI manual and all MDS item sets were available for download, that was on August 24th, I did forward the information to everyone on my email distribution list. So you should have the most recent versions at this point. Excuse me. Here we see my updated disclaimer. As I've mentioned before, we REI coordinators have not received any formal training from CMS on the changes coming in October. However, the CMS videos posted on their YouTube channel are there to watch anytime. And I strongly encourage you and your team to check out the CMS YouTube channel regularly for those and other future training videos that they will probably post with updates. Also, way back in May, I mentioned that the cause, and I said I would speak more on that topic later, but I didn't say how much later. While I did mean later in that presentation, it didn't happen. And that's because I want to go through the entire process with you in the order prescribed in the manual, and the cause come later in that process, after you've collected all the data that you need to be able to complete them. So we will eventually get to the cause, but in the meantime, feel free to read the manual, which I strongly encourage you to do anyway, and do some research and discover how the cause work if you don't already know. And as you can see on this slide, no AI was intentionally used in the preparation of this presentation. So if it was used, I didn't know about it. All right. During our last session, we discussed how to determine the primary medical condition or category that qualifies a resident for a Medicare Part A stay. We also went over the definitions for active and inactive diagnoses, which criteria is used to determine if the diagnosis is active or not, including required documentation and timeframes, as well as what supportive documentation was acceptable. We pointed out where to look for information within the medical record, and we also covered how a resident's functional status and limitations can be affected by diagnoses, what constitutes skilled nursing monitoring, and we reviewed several examples. We learned that UTIs have a different look-back period, along with 2 very specific criteria that must be met in order to code UTI as active. And last, we went over how to determine if a resident had major surgery within the required time frame, excuse me, prior to long-term care admission, and if they required aftercare in a SNF. Okay, before we get into today's topics, I'll respond to a few of the questions submitted in your 719 post-session evaluations. The first question asked was, if a resident is admitted to the SNF with a UTI, does the SNF need the criteria used to make that determination? According to page 356 of the manual, the answer is no. It explains that, quote, if the diagnosis of UTI was made prior to the resident's admission, entry, or re-entry into the facility, it is not necessary to obtain or evaluate the evidence-based criteria used to make the diagnosis in the prior setting. A documented diagnosis of UTI by the physician or allowed practitioner prior to admission is acceptable. This information may be included in a hospital transfer summary or other paperwork, close quote. The paragraph after this one was confusing to me and maybe to you as well. So I asked for clarification from the RAI coordinators panel. Their response was, quote, residents are often sent to the ER for an evaluation of some change in condition with discharge return anticipated. A urinalysis is usually ordered as part of the evaluation and often comes back positive with bacteria present. The resident is started on an antibiotic for a UTI based solely on the preliminary results of the urinalysis and the change in condition. The resident returns to the SNF while the urinalysis, which is the definitive diagnostic test, is still processing. The SNF is expected to monitor for the results, including any sensitivities to determine if the resident did have a UTI versus a contaminated specimen, and if the resident is receiving the correct treatment. In this situation, the SNF must use evidence-based criteria to evaluate the resident and determine if the criteria for the UTI was met and ensure that there is a physician-documented UTI diagnosis during the look-back period when completing I-2300 UTI. To wrap up this response, remember there must be evidence in the medical record that one of the three criteria listed in number 1, and that's either McGear, NHSN, or Loeb, was used to diagnose it, and there must also be signed documentation by the resident's medical provider, and both must be within the last 30 days. If all requirements are not met, a UTI cannot be coded as active at I-2300. And you can ask your infection preventionist for a criteria worksheet, whichever one your facility uses, whether it's McGear, NHSN, or Loeb, excuse me, or you can find one on the internet. And my suggestion would be that as soon as a UTI is suspected, a worksheet be started, and that could be the whomever it is, or it could be your infection preventionist if you want to get them involved at that point in time. So you should start a worksheet right away to document as the information becomes known. And this way you'll have all the data right there handy to discuss with the physician so that they can call the next move. You might actually have to recommend it to them. All right. Our next topic for follow-up is about antipsychotic medication and the related documentation requirements. Around 2014, CMS noticed an increasing and alarming number of residents who were on antipsychotic medications without the appropriate diagnoses. In addition to the usual recertification survey activities, surveys were tasked with focused reviews on residents who were on antipsychotic medications and the corresponding diagnosis for which they were prescribed. Many had no such diagnosis. Over the next 3 years, CMS concluded that in many cases, drugs were being used as chemical restraints. Residents who had behaviors, including but not limited to wandering, continuous vocalization, and resisting care, were not redirected or given one-on-one attention or encouraged to participate in a meaningful activity. They were given medications that affected their mental mental processes and rendered them inert. I remember entering buildings unannounced around 8 a.m. for annual recertification surveys. Parked by the nursing station every time were multiple residents, slumped over in their wheelchairs, totally oblivious to the activities happening around them. In 2017, federal regulations were updated, and just recently, CMS began conducting audits in facilities that remain non-compliant. Hopefully, you are all familiar with Appendix PP of the State Operations Manual, otherwise known as the SOM. One of the requirements for a facility to become certified by the Centers for Medicare and Medicaid Services, CMS, is the signing of a legally binding enforceable agreement in which the facility promises to comply with the federal regulations as established by CMS. The SOM contains those regulations and is the document by which surveyors determine your facility's compliance. There's a link to the current SOM in the resource section of your handout. If you haven't already, I highly recommend you download a copy, become familiar with it, and keep it handy for future reference. Now that you know where this requirement comes from, let's look at FTAG 605. Which states that residents have a right to be treated with respect and dignity. This includes the right to be free from physical and chemical restraints imposed for the purpose of discipline or convenience, and are not required to treat the resident's medical symptoms, consistent with subsection 483.12A2. When a resident is given an antipsychotic medication without a valid psychiatric diagnosis, it can be considered, and usually is, being used as a chemical restraint. Again, think about your resident who wanders into others' rooms or constantly paces, attempts to elope, or maybe they constantly call out for someone or something. Behaviors of this type call for staff to implement appropriate interventions, such as redirecting, engaging the resident in an activity that they enjoy or find meaningful, or spending some one-on-one time to connect with them, acknowledge their presence, and show them they are seen and cared for. Dignity. Imagine the resident as your beloved grandmother or grandfather, and how you would want that dearly beloved person to be treated. At a CMS training I attended back when they were held in person, we heard about an elderly gentleman with dementia whose room was close to the elevator. Whenever he heard the distinct sound of the elevator announcing its arrival, ding, he became very active and started punching the staff providing care at the time. It turns out in his younger days, he boxed professionally. And when he heard that elevator ding, he became that boxer in the ring. Another example was a resident with dementia who would go up and down the hall every afternoon around 3:30. Well, she used to walk to the bus stop to meet her children as they got off the school bus every day. Her care plan was revised to include a staff member joining with her to walk and have a meaningful conversation about her memories of those days. In the boxer's case, the solution was to move him to a different room where he could no longer hear the elevator's bell, which to him was the signal to get ready to rumble. In our July training, we looked at this example showing an inactive diagnosis of schizophrenia. We learned that it could not be coded as active because there was no documentation of specific behaviors for at least 6 months prior to the medication being started per professional standards. Well, what are the professional standards, you ask? I'm glad you asked. The Diagnostic and Statistical Manual of Mental Disorders, 5th version, text revised, or DSM for short, is considered the authority on professional standards when it comes to prescribing all medications. The DSM consists of three major components: diagnostic classification, diagnostic criteria sets, and the descriptive text. The DSM lists the required criteria that must be met to determine each diagnosis. In the resources at the back of your handout is a link to an online DSM-5 where you can read the very specific criteria required to make a diagnosis of schizophrenia. If a resident with antipsychotic meds is just being admitted to your building, make sure you receive the documented history that led to the diagnosis for that antipsychotic medication. If a resident has been in your building for a while and an antipsychotic appears in an order or on the MAR, look for the necessary documentation. And if there isn't any, have a conversation with the IDT, the physician, and the pharmacist regarding the same. Now, I'm not even going to get into the requirements for the need of a discussion with the resident and or a representative, along with signed informed consents, etc., before you can administer these medications. Hopefully, your facility has very clear policies regarding this, and all physicians and pharmacists who enter your building are familiar with them, as well as the nurses, since they're the ones administering the medications. Because trust me, you do not want to receive a letter from CMS notifying you that an audit for schizophrenia is in the works for your facility, unless, of course, all the required documentation is in place. If you don't already, I strongly encourage you to regularly review and stay up to date with all psych meds, including their generic and brand names, and be sure to pay attention to any new products that may come to market. The MDS coordinators and all nurses passing meds must continuously be on the lookout for an antipsychotic being prescribed to any resident. And when you see a new psych med on a resident's medication list, a red flag waving along with a loud warning sound should go off in your mind and prompt you to follow up accordingly. By the way, it is very rare for individuals over 40 years old to be diagnosed with schizophrenia. The third and last follow-up question we'll address today is about section GG. The question was, must staff documenting this section be licensed? One of the more frequent questions I do receive from providers is, can LPNs do this particular section or that specific section of the MDS? So I've modified this question to ask, who can document on the RAI? This way, we will address exactly who can document all sections of the entire assessment. Sound good? So the answer to the question of who can document in the RAI is, well, it depends. We know from the federal regulations that a registered nurse must conduct or coordinate each assessment with the appropriate participation of other health professionals. Even facilities that have been granted an RN waiver under 42 CFR 483.35E are required to have an RN conduct or coordinate the assessments and sign off that the assessments are complete. Nevada currently has one facility with the RN waiver in place, and hopefully they are compliant with this. On page 1-4, the manual provides instructions regarding who can participate and other parameters for complying with the regulations. We also know that the end goal of every assessment is to accurately reflect each resident's unique, individualized overall status. And the instructions clearly indicate that the collection process includes direct observation, interviews with the resident and their representative, and communication with direct care staff from all shifts. And I'm thinking perhaps the words, but is not limited to, should be included in that third statement. Includes, but is not limited to, direct observation, interviews, and communication with direct care staff from all shifts. Given the requirements of participation of appropriate health professionals and direct care staff, Completion of the RAI is best accomplished by an interdisciplinary team that includes nursing home staff with varied clinical backgrounds, such as a social worker, speech-language pathologist, occupational and physical therapist, dietary and activities staff, and don't forget the resident's physician. The pharmacist may also have a contribution to make. The bottom line is that everyone who documents any portion of the MDS must be fully trained and deemed to be competent to do so, regardless of their licensure status. By the way, tag F838 in the SOM requires that each building complete a facility-wide assessment as often as needed, but no less than annually. During this assessment, facilities need to consider the status of their resources. For example, as it relates to this topic, the number of staff, clinical and otherwise, their skill sets, specialized training, abilities, and competencies when they create their facility policies regarding who can contribute to the RAI. Keep in mind that most of the information entered in the MDS is collected from the medical record, which was documented by licensed professionals. Your facilities process might be that your admissions or business office enters information in Section A, such as legal name of resident, social security number, Medicare or Medicaid numbers, date of birth, etc. If they do this, the coordinating RN needs to ensure the information is correct, so they won't have to play detective and figure out why there's a missing assessment later down the road. All this to say, the person entering data into the MDS may or may not be licensed, but they must be trained, competent, and know what they are doing. One caveat to this is that the Nevada Supportive Documentation Guidelines, which are in the process of being updated, may have more stringent requirements. We'll have to wait and see what they say when they become available. So the entire IDT will need to be involved in determining how to accurately code each of the data elements in Section GG. Chris will cover the coding of Section GG in his presentation. I just want to mention also there was a great tool created by APACN, AAPACN, American Association for Post-Acute Care Nurses. For those of you who are members, there's a great tool on there for CNAs to be able to document so that the IDT team can later go through that and figure out how to code the items. As I mentioned a moment ago, one question I've been asked frequently over the past 9 years is, can LPNs do this particular section or that specific section of the MDS? This was debated so frequently that in June 2021, I took the matter to the State Board of Nursing, where they agreed a definitive answer was needed. A subcommittee was formed. We met virtually, did the research, consulted national standards, and discussed all of the related variables and concerns. On January 19th, 2022, the board decided that LPNs may indeed complete parts of the MDS, but only if they are trained sufficiently and deemed to be competent to do so. On April 5th, 2022, I sent an email update to everyone on my distribution list. You can also find the practice decision on the State Nursing Board's website. See the link in the resources portion of your handout. This morning, related documents were included with the slide handouts sent to everyone who had registered by the deadline of this morning. Please note the 2 requirements that must be met. The RN who is coordinating or overseeing the assessment process must assign the specific task to the LPN, and the LPN must have completed the necessary training. The Nevada Administrative Code, or NAC 632.242, describes the requirements for the LPN to be qualified, as well as the documentation needed and annual verification of the LPN's continued competency, updated training, etc. Facilities must maintain documented evidence of this training and competency. competency in the personnel file in case surveyors ask to review it. And since the world of MDS is constantly changing, updated training and competency evaluations will also need to occur and be documented as needed. This is just a reminder that each person who signs at Z0400 is certifying or swearing that the information they've entered is accurate and true. They also acknowledge that they and/or their company will be held accountable for the submission of any false information. All right, in 2019, we started preparing for standardized patient assessment data elements across the entire care continuum. Thanks to the Impact Act of 2014, CMS started revising the assessments for all post-acute care facilities to come into alignment with standardized patient assessment data elements, or SPADES. And beginning October 1 of this year, CMS will no longer be comparing apples to oranges, but apples to apples. And these changes will make that process so much easier to do. And the reason I mention this is because there are many differences in some of the coding going forward. Our last session ended with section I, so today we'll pick it up at section J, health conditions. Okay, there have been several updates to section J regarding pain, so let's take a look. The first change we see from the previous item set is that item J0400 has been retired, and now there is J0410 instead, but it's still about pain frequency over the last 5 days. There is another significant difference here from what we saw at J0400. Notice the coding is reversed. Instead of almost constantly being listed first and coded as a 1, we see that a code of 1 now indicates rarely or not at all. The worse the pain is, the higher the number, ending with 4 almost constantly. And the manual points out that for all interview items, of which this is one, you need to be sure to ask these questions exactly as they are written. Page J-12 of the manual has detailed guidance on how to help the resident narrow down the answer if they don't seem to know exactly how to respond. And once again, as you explain the options from which they have to choose, you need to read those options exactly as they are written in the RAI, in the item set. Next, we have J0510, which replaces J0500. This item asks the resident how much of the time their pain has made it hard for them to sleep at night. Again, watch the reversal of the numbers and frequency. Also notice that on this question, the code for unable to answer is 8, whereas it was a 9 for J0410. J0520, pain interference with therapy activities, is new. If the resident received no rehab therapy in the past 5 days, coded as 0 does not apply. Again, we see an 8 for unable to answer. I would caution you to be sure to pay attention to these changes of the 8 and 9 unable to answer so that you'll get used to them and not code inaccurately. The coding tips indicate these items should be based on the resident's interpretation of the provided response options for frequency. If the resident is unable to decide between 2 options, the assessor should code the option with the higher frequency. Notice the inset box with the definition of rehab therapy on page J-14, as well as the first paragraph on page J15 of the manual. Page J-16 of the manual has a couple of examples of how to interview for J0530, which you should read on your own and become familiar with. Okay, we're all familiar with the definition of rehab therapies, but page J-15 of the revised manual points out that a residence therapy may also include treatment supervised in person by a therapist, nurse, or other staff, or the resident may independently carry out a prescribed therapy program without staff members being present. We are also reminded that restorative nursing programs are not included in rehab therapies. Why? Excuse me. Because restorative programs are nursing programs developed and carried out by nursing staff. They focus on preventing contractures and regaining or maintaining range of motion. Also, they do not require a physician order. Rehabilitative therapies, on the other hand, are developed by therapists. They focus on helping the resident to gain or regain lost strength, increase endurance, and or muscle memory after an illness or surgery. And they do require a physician's order. As we can see detailed in the updated manual, this may be carried out by someone other than the therapist. J0530 is new and asks about pain interference with day-to-day activities excluding rehab therapy and uses the same coding as J0520 with a code 8 if unable to answer. Again, per the manual's instructions, if after trying to assist the resident to narrow down their response, they still are not able to provide a definite answer, you may code for the higher frequency. Notice the difference in the new definition of the completed pain assessment interview compared with the old one. Also, if you had time, which I'm sure you don't, I would suggest that you read the manual from page 1 to page 1710. Yes, that's how long it is now, folks, 1710 pages. But since I'm sure you are pressed for time, I encourage you to read all information in red because that is all the new and or changed material. And there's a lot. Moving on to section K, the first change we see is that K0510 has been replaced with K0520. Excuse me. Information collected here pertains to the same nutritional approaches as before, except now you have 2 more columns that need to be addressed. In addition to the resident status while not a resident and while a resident, you also have now on admission and at discharge. The assessments also have guidance regarding timeframes for each option at K0520, and you need to become familiar with these. The fact that the parameters for each item, 1 through 4, are present right there on the document itself should be helpful in determining which will apply. Excuse me. And notice that the instructions highlighted here in green says you should check all that apply. So this just shows you the difference between the current version and then the one effective in 11 calendar days. So you can see the distinct differences side by side. By the way, the manual provides 2 important coding tips on pages K-12 and K-13. Says for K0520B, only feeding tubes used to deliver nutritive substances and or hydration during the assessment period are coded here. So if you were flushing to keep them patent, would not be included. Only if you are delivering nutrition or hydration during the assessment period, you should code at K0520B. And then for K0520C, the instructions are do not code a trial of a mechanically altered diet during the observation period. The updated item sets do not include any new data elements for skin conditions, but there are a couple of coding notes in the manual in red that you need to read and understand. See page M-12 in the manual to ensure you understand the difference between closed and healed. On page M-6, there is a reminder about skin changes at the end of life. The acronym is SCALE, S-C-A-L-E. Also referred to as Kennedy terminal ulcers. These are considered skin failure. And the acronym of SCALE indicates this type of wound typically occurs when someone is in the end stage of life, usually with 2 weeks or less until death. On a side note, if the resident is on hospice while in your facility, the hospice nurse should be able to confirm the diagnosis of this condition. Since pressure is not considered the primary cause of this integumentary issue, these are not coded in Section M. Regarding where to code this particular type of wound, the manual doesn't say. My best guess is it would be at M1040D, as in Daniel. Excuse me. Moving on to Section N, we see that there are some changes beginning with N0410, medications received, which is now history. It's been replaced with N0415, high-risk drug classes, use and indication. This new item has 2 columns in which to indicate 1, the resident is receiving a specific drug, and 2, the need for it is indicated in the medical record. For N0415, instead of recording the number of days in the past 7 that the resident received a particular medication, as shown on the previous slide, you will now check the box in column 1 to indicate the medication was given during the last 7 days, or since admission/entry or re-entry if it's less than 7 days prior to the ARD. Indication noted is defined in the SOM, page 127, as the identified documented clinical rationale for administering a medication that is based upon an assessment of the resident's condition and therapeutic goals and is consistent with manufacturer's recommendations and/or clinical practice guidelines, clinical standards of practice, medication references, clinical studies or evidence-based review articles that are published in medical and/or pharmacy journals. There needs to be supportive documentation in the medical record for each medication in each drug class. For example, 2 anxiety meds are being administered. There needs to be an indication for each medication in the record. Each medication separately needs to be indicated why they need to be on it. And the need to document the medication by pharmacological classification, not how it is being used, has not changed. So it's not how it's being used, but it's the pharmacological classification that needs to be noted and indicated why they need it. Note that antiplatelets and hypoglycemics are 2 new drug classifications that have been added here. Regarding the 2 new drug classes, the RAI manual, starting on page N-8, some of the new red verbiage is shown on this slide. So do not code antiplatelet medications such as aspirin, extended release, dipyridamole, or clopidogrel as an anticoagulant at N0415E. Anticoagulants such as target-specific oral anticoagulants, which may or may not require laboratory monitoring, should be coded as an anticoagulant in N0415E. Excuse me. We also see that you're not to code flushes to keep an IV access port patent as an anticoagulant. And keep in mind that transdermal patches are generally worn for and release medication over a period of several days. So to code N0415 only captures the medication if the transdermal patch was on the resident's skin during the observation period. Going back to the RA manual on page N-8, it continues to page N9. So again, reading all the new information as indicated by red italicized font is highly recommended. All right. Today we covered during this session the required criteria for coding UTIs active, that is the type and source, the documentation requirements for legitimate use of antipsychotics, who can participate in completing the RAI, changes and new items in Section J, pain, updates regarding rehab therapies and residents carrying out their programs independently, changes in Section K, nutrition, and changes in Section M and N. There is a lot of new information written in red, and everyone needs to, at the minimum, read the red. All right, Mary Parker says, I have several LPNs in the MDS position. According to what you said, I need to put something in the personnel file that the MDS training was completed and that they are competent to complete the MDS. Yes, Mary, there needs to be proof that they have had the training from wherever they got it. It could be from CMS or somebody else out there who does professional training regarding the job, the position of MDS coordinator. They could actually get it from APACN. But yes, anybody who's been trained to complete parts of the MDS needs to have the training, and they need to have the evidence in their personnel file.
Welcome, everybody. For those of you who don't know me, my name is Chris Christiano. I am the State Case Mix Coordinator with Nevada Medicaid, and want to thank you all for taking time out of your day to attend this presentation. And of course, thank you to Carol, my co-presenter, for an informative presentation. I know there's probably a lot of questions at this point. I was hoping that we would have our PDPM transition process finalized in stone by the time of this training, but during the months of July and August, as many of you know, we have a stakeholder work groups. They were stalled, and we are just now in the process of getting back on schedule. Okay. The information I have is that we are still transitioning to PDPM, and we will not be utilizing an OSA. I will review some updated information in the presentation about the transition dates and the details, but do note that these dates are subject to change. And of course, as updates are available, they will be sent out to those who are on the PDPM email list, which you will find at the end of my presentation today, if you do not already have it. And finally, I'll ask that if you, at the end of the presentation, you have any questions that I'm not able to answer at this time, please allow me 1 week to obtain the correct answer, and I will respond back to you with an email. Okay, our agenda. So our agenda today will include a review of PDPM transition and some information on coding diagnoses, on your assessments that is important to understand. And we will also discuss coding isolation. We will review some details on Section D, moods and behaviors, and some new changes in that section. And then we will finally look at Section GG, the nursing component of that Section GG. And I do realize that we train on Section GG in our first training in May. But with that being said, that is GG is the bulk of the change we will see on our review items. And of course, for those who weren't here on those trainings, it's important to review again. Okay, so our PDPM transition. As many of you on this training are aware, Nevada Medicaid will transition to the PDPM payment model. Our target date for full transition is still July of 2024. And what that means is basically by that time, we will be getting full PDPM data from your facilities. We will start reviews sooner than that with the information that you are submitting. Our stakeholder work group, which some of you are representatives of or somebody from your facility is, have been participating, and this was started in January or February of 2023. And we've been discussing that transition. We are still actively engaged in the PDPM transition process as well, and we are working with and receiving directions from Myers and Stafford on that. So any changes that are upcoming that I don't mention in this training, maybe that you're aware of, I have not been informed by our consultants at Myers and Stafford. Okay. I'm sure that you know that Section G will be going away as of October 1st, 2023, and facilities will use Section GG to obtain the nursing function score. I've been informed by Myers and Stafford that most of the items that we previously reviewed in the RUG 3 will still be reviewed with the PDPM transition. So unless there is some unforeseen changes or more delays, the facility process, as I said, will start in January of 2024. Reviews will be done remotely. That is our goal. We want to streamline the review process, and there will be more information forthcoming on that as that procedure progresses, okay? MDS coordinators at the facilities being reviewed will be notified prior to the review process. And as always, they will be annual reviews, and we'll be looking at submitted data for a given quarter. One of the things that's not been finalized and we've been discussing in the stakeholder work groups is the point of time methodology versus our CMI average for the review period. Everyone, both our side as well as the providers, seem to be leaning towards a CMI average period, okay, that we look at. Historically, as you know, or you may not know, we've used the point in time method. And again, updates will be sent through MDS coordinators and providers from the PDPM mailbox. All right, diagnosis I0020. So the MDS states that these items in this section are intended to code diseases that have a direct relationship to the resident's current functional, cognitive, mood, or behavior status. It also reflects current treatments, nursing monitoring, or risk of death. One of the important functions of the MDS, of course, as we all know, is to generate and update an accurate picture of the resident's current health status. So be sure and complete this section. If it were left blank, I've been told that the assessment will go through, but it will not produce a HIPS code, which we don't want. We won't have data to review, and I assume that will reduce your payment. When doing assessments, be sure diagnosis is reflective of the status at the time of the assessment. You will not want to carry the admission diagnosis. And an example of this is, let's say the resident came in for a fractured hip and repair, and that diagnosis, they've been there for months, that diagnosis is long gone, and of course you would want to update that diagnosis. So here's our I020 section. Our example from the MDS guides us to enter the medical condition that best describes the reason for the admission. Sources that are acceptable use for physician diagnoses are the recent history and physical, any transfer documents that you receive, discharge summaries, progress notes, and other resources as available. We then, of course, proceed down to I-20B, which is our ICD code. And a note here is that when an acute condition represents the primary reasons for the resident's SNF stay, it can be coded here. However, it is more common that a resident presents to the SNF for care related to an after effect of the disease or condition. Therefore, I guess any subsequent encounter codes should be used. I strongly encourage everyone to review the MDS manual for multiple examples to code this properly. This has been stressed by Myers and Stafford as being one of the areas that can be an issue. So active diagnoses in the last 7 days. So what's considered an active diagnosis? Active diagnoses are physicians' documented diagnoses in the last 60 days that have a direct relationship to the resident's current functional status, maybe their cognitive status or mood or behavior, medical treatments, any kind of nursing monitoring during the 7-day look-back period. So you notice we have 2 look-back periods. So we need to determine if the diagnoses are active. Is the resident currently being affected by this? Okay. So one exception to note here, as Carol mentioned in her training, of course, is I-2300 UTI, which does not use the active 7-day look-back period. It happens to have a 30-day look-back period and other specific coding criteria, which Carol mentioned. Also, do not include conditions that have been resolved here. Do not affect the resident's current status or do not drive the resident's current plan of care during that 7-day look-back period. Those would most likely be considered inactive diagnoses and possibly result in an error. So, isolation. So we see the definition of isolation here. Something to note here is active infection, meaning the resident is symptomatic or has a positive test and are in the contagious stage, okay? That is what's considered isolation. Alone in a separate room as well because of an active infection. So some isolation requirements. We need a physician's order, of course. We need some documentation supporting the need for a private room. We'll be looking for documentation to support the need for the resident to remain in their room as well, if that occurs during those look-back periods. There is clear instruction, of course, in the MDS on how to do this. I encourage everybody to look at all these items we reviewed today. Documentation must most importantly support the medical necessity of that isolation. There must be those 3 things listed above, okay? Isolation continued. So continuing, the documentation must reflect the care is over and above standard precautions as well, meaning either that transmission-based precautions such as contact, droplet, or airborne must be in effect. The resident is in a room alone because of an active infection and cannot have a roommate. The resident must remain in his or her room, and of course, this requires that all the services that they're receiving be brought to the resident's room, including rehabilitation, activities, dining, etc. Okay. So some things here, isolation is not coded in these circumstances. If the resident has only a history of infectious disease, for example, they had MRSA in the past, C. diff, but are currently displaying no active symptoms, okay? Urinary tract infection. So with that previously mentioned, there are no active symptoms. If we note that somebody possibly has isolation orders and there's not notes that show that they're having active symptoms, that would be possibly something we might question, okay? Urinary tract infections, encapsulated pneumonia, and wound infections as well are not coded for isolation. So isolation considerations here. Isolation considerations, there's psychosocial risks associated with isolation. And it's really important that psychosocial needs are balanced with infection control. If a facility happens to have to transport a recipient who is on isolation to receive services that are needed, the facility may still code 00100M for single room isolation, since it's maintained in the facility. But again, those criteria with the order and the other things I mentioned need to be documented. We also like to see frequent assessment with this. We don't want to see somebody who's in the room and doesn't have notes of why they're in there on isolation, that, the condition has improved, got worse, what treatments are being provided. It's important to document all those things. So moving on to moods, and our first one here is B0700, make self understood. This plays directly into the PHQ-9, so it's important to mention that. We see make self understood, the ability to express ideas and wants. It's important to know when we assess this that we must consider verbal and nonverbal cues a resident may be giving. The Nevada documentation goes beyond what's in the MDS, and it states that documentation guidelines require an as evidenced by statement within the ARD. Okay, so Carol went over this too a little bit. Who can complete the BIMs, the PHQ-9, the PHQ-9OV MDS items? RNs, yes. Social workers, yes. LPNs, yes. With the criteria, of course, that Carol mentioned, supervised by an RN, I believe, or under the supervision of an RN. Do you have to document that? I think we agreed that it's important to show that somewhere in the documentation that is occurring. Okay. And Carol, do you have anything to clarify on that you'd like to mention that you didn't already, since you went over it pretty thoroughly?
Can you hear me?
Yes.
Okay. Excuse me. The explanation is in the one document that I sent this morning with the handouts. It gives the Nevada Administrative Code regarding all the details. So they should read that and become familiar with it. And if they need clarification on something, feel free to let me know.
And you may have your own facility policies as well that you may be required to follow. Okay. So that would be something to pay attention to. All right, Section D, mood, our first Section D item. Okay, move on here. And according to the MDS, mood disorders are underdiagnosed, undertreated in nursing homes, and they can be a significant source of morbidity. Social isolation is also another concern with residents, as it's a factor for physical and mental illness. And with that said, I think we have done trainings in the past on this section. In fact, I know we have, and it's been an area where quite a few errors have occurred. So let's review. This section has been revised since our last reviews, and the PHQ-2 has been added to gather more data with the PHQ-9. Apparently, this may save time because you don't necessarily have to proceed to the PHQ-9 interview when patients score less than a 2 on items D0150A2 or D0150B2. Another change to this section is also D0700, a social isolation assessment. And some of the interview questions in the sections to note here have a 14-day look-back period. Our first question we see is, should the resident mood interview be conducted? If no, resident is not understood, we skip and move on to complete D0500, the staff assessment, and D0600, PHQ-9. If yes, we continue to D150 and the PHQ-2 through 9. So D01 assessment. We want to assess the resident's ability to understand the methods that were used, any interpretation services. And when we review, it's important that the documentation reflects this. What methods were used in the interview? Did the resident require any assistive devices? Were they hard of hearing? Did they require an interpreter? Did you use sign language or cue cards? Failing to document these things can be a source of error. And these are things that we've noted in past reviews. So take note of that, please. And of course, as I've stressed on these sections, please review these sections. This is one of the sections I said that we do see errors in. Okay, our D0150 resident mood interview, the PHQ-2 through 9. You see that up here on the screen. So this interview starts when D0100 was coded 1, and its purpose is to screen for symptoms of depression. It also provides a standardized severity score and a rating for an evidence of being depressed, a depression disorder. As we previously said, mood disorders are common in nursing homes and often underdiagnosed and undertreated. And again, it must be documented if an interpreter was used or any other methods to communicate with the resident. The MDS manual provides many good examples of situations and types of assistive devices that might be used. And as I said, I encourage you to familiarize yourself with this section. Also, look at the Nevada documentation guidelines for any additional requirements on this one as well. Although I will say that has not been updated yet with this. So we're going to refer to the MDS manual until that is updated on any sections or items that are not included on the Nevada documentation guidelines and have been updated in any of that. So I hope that's clear. Okay, so then that leads us to our total severity score. And this is just basically a summary of all the frequency scores on the PHQ 2 through 9. And it indicates to the clinicians the extent of potential depressive symptoms. It doesn't diagnose mood disorders or depression, but as I said, just provides that standard score which can be communicated, and then hopefully follow-up treatment will occur. All right, that leads us to next the staff assessment, the PHQ-9OV. And there is a Nevada documentation guideline requirement on this one, as evidenced by statements are the things that are different from the MDS manual, as well as must include the frequency. So here are some examples of staff responses. So Harry is feeling down is evidenced by spending most of his time in his room daily over the past 2 weeks. Lily is always tired for the past 8 out of 14 days because she wanders during HS. This is how basically would make us really easy for us as reviewers if we see this. So I encourage you to look at those documentation guidelines, start using this AEB. As many of us had to do in nursing school, we had to always use that. And we do use that with the documentation guidelines. Here is our staff assessment. So those conducting this interview, staff from all shifts should be interviewed who know the resident best. Okay, so make sure you're getting a wide array of information before coding this. Okay, look at whatever notes you have available, whatever resources. When you do the resident or when you conduct the interview, make sure you conduct that in a location that protects privacy, of course, focusing the discussion on specific symptoms listed on the assessment rather than expanding into some lengthy clinical evaluation or such. Okay. Many of the same administration techniques outlined in the MDS for the PHQ 2 through 9 can be followed when this staff interview is completed. And also encourage staff to report symptom frequency in their notes or in the reportings they give to you, okay? Even if the staff believes that it's something that's unrelated to depression, okay? Explore unclear responses is another thing we want to do with this to make sure that this is accurately assessed. And if the frequency can't be determined by staff interviews because the resident has been in the facility for less than 2 weeks, talk to family or significant other and review the transfer records, okay? Has everybody seen D150 through D0500, Carol? Is that the next slide that's up there? Carol, are you there? Are you seeing D0150 and D0500 considerations?
Yes, Chris.
Okay, great. Just wanted to make sure my slideshow isn't working. I'm having to do 2 things here.
I was double muted.
Okay, so depression can be associated with psychological and physical distress. It contributes to poor adjustment to the nursing home, loss of independence, chronic illnesses, increased sensitivity to pain, as well as decreased participation in therapies and activities that you're administering, often due to self-isolation. Functional status is also affected, and staff will see resistance to daily care, a decreased desire to participate in ADLs, and just generally poor outcomes with our recipients in facilities. D0150, D0500 considerations continued. So how do we prevent and reduce the effects that we see with depression? We can do this by goal setting, improving the residents' quality of life, and ensuring resident safety, okay? We can also assess and identify causes that are contributing factors for symptoms. We could plan and develop interventions, treatment, personal support, or environmental modifications that could address symptoms. And these are things that, of course, we will be looking for in documentation. All right, moving on here. So RUG item D0600 again. Again, we have the total severity score for the staff assessment, as we previously mentioned. Not a diagnosis, but just something that can be communicated with other personnel. Okay. Social isolation. This is the new item here. So the definition that they give is that refers to an actual or perceived lack of control with other people, such as living alone or residing in a remote area. This item is intended to be a resident self-report item, okay? And that's something that Carol and I discussed prior to our training today to make sure we were clear on that. So again, a resident self-report item. If they decline to, we're not to ask, okay? Social isolation tends to increase with age, and it's a risk factor, again, for mental illness and other mortalities and bad outcomes in the facility, okay, with treatments and whatnot. No other sources should be used to identify the response here, okay? All right, on to section GG. So section GG is our big change here, and we may or may not present the most problematic, it may or may not present the most problematic coding and documentation issues for the MDS coordinators, as well as us as review staff. We really won't know until we start to review this section how difficult it will be. As we get more information, it'll be more helpful and meaningful with these trainings to have that, and to review past reviews that we've done, and to look at how errors occurred and what we were seeing, and then of course to compare those to whatever guidelines we come up with the Nevada documentation guidelines. Once that's finalized, hopefully by December, it will be finalized, okay? The look back section for GG, as you know, is 3 days, meaning the ARD and the 2 previous calendar days. There's 7 item sets there that make up the nursing functional score. And these are the items that, of course, we'll be looking at. Historically, in these presentations, as I said, we've had that information from past reviews to look at, but we don't have that at this time. Also, some things to remember here, considerations. It's very important in section GG to be sure you are recording the resident's usual performance. That's one of the things that's stressed throughout the MDS manual and all the trainings I've been to on this. Be sure and document what methods were used to determine the usual performance. And something to think about here is maybe that a resident's functional status can be impacted by the environment or situations that they can encounter in the facility. So try your best to observe the resident's interactions when in other different locations and circumstances, okay? Do not record the resident's best performance, and do not record the resident's worst performance, but rather record the resident's usual performance. So that's where I see maybe some clarification needed with maybe the Nevada documentation guidelines. I anticipate as we look at notes and see how we try to determine this, that's going to be an issue. Okay. So we have our decision tree here. This should be very helpful. As you remember, we had something similar with section G. Make a habit of utilizing this decision tree when coding for the items in section GG or toileting hygiene or any items, okay? The 6-point rating scale definitions include the following types of assistance. We have setup and cleanup, touching assistance, verbal cueing, and lifting assistance. Also, if helper assistance is required, score according to the amount of assistance provided. When we update the Nevada documentation guidelines, it will probably most likely mirror this information. And it may require some type of as evidence by statement. But until that's updated, refer solely again to the MDS. So some steps for assessment here for GG. As I mentioned previously, it should reflect accurately where the information for the assessment was received from. That's something we're going to clearly want to see in the notes. And the steps for assessment are as follows. So we use direct observation. We use the resident self-report, reports from qualified clinicians, care staff, or family that's documented in the medical records during the 3-day assessment period. That helper assistance thing that we talked about earlier is required. Consider only facility staff when scoring. And I'll define that here shortly, what that is, because that's something that's mentioned in the MDS manual. Activities may be completed with or without assistive devices as well. Okay. And then admission functional assessment should be completed prior to the person benefiting from any treatments or interventions when possible, but don't delay treatment, of course, if it's necessary. So our item here, eating, the important thing to note about this one is that the administration of tube feedings and parenteral nutrition is not considered when coding this activity. All right. Whoops. I don't think I moved ahead there. Sorry. All right. Toileting hygiene. So this is based on the resident's need for assistance in managing clothing and perineal care. Cleansing before and after voiding or having a bowel movement. The note here on this item is that if the resident has an indwelling urinary catheter and has bowel movements, code the toilet hygiene item based on the amount of assistance needed by the residents before and after moving their bowels. Okay. All right, sit to line is our next item. So as stressed, the key to properly assessing GD items are allowing recipients to perform these activities independently. If helper assistance is required, it's important to understand that definition. We see that definition again. So it's important to note here that it does not include individuals hired, compensated, or not by individuals outside of the facility's management and administration, such as hospice staff, nursing certified CNA assistants, students, etc. If we see this in a review, this most likely would result in an error. Therefore, when helper assistance is required because a resident's performance is unsafe or of poor quality, make sure that you maybe identify that it's facility staff. That would be helpful. Okay. That may be something we might define further in the Nevada documentation guidelines as well. All right. And as I said, of course, don't hold back treatment to, to complete the assessment. Okay. Sit to lying is our next item here. Oops. So when coding the resident's usual performance, effort refers to the type and amount of assistance a helper provides in order the activity to complete. So make sure you note that definition. and try to reflect that in your documentation. Okay, don't think about the resident's potential here. That would be something important. And I think I would probably have an issue with that if I was to document. I'd say, oh, well, they did pretty well. They almost did that, so we'll just document it that way. Do not do that, okay? Our next one, sit to lying here again. Or I'm sorry, lying to sitting on the edge of the bed, okay? So I want you to look at the examples in the MDS manual for this. Your judgment should be used to determine what is considered a lying position for a particular resident, okay? So if the resident's feet don't touch or reach the floor upon lying to sitting, the qualified or a clinician will determine if a bed height adjustment is required to accommodate the foot placement of the floor. And, if any other devices are needed for that, it's important to capture that in the documentation, such as back support, if the bed needs to be elevated, anything like that, okay? Code 88, activities as not attempted due to medical condition or safety concern, if that is the situation. So our sit to stand item here, not much really to say about this other than use the decision tree for this. A stand assist lift is used and 2 helpers are needed to assist with the stand lift and coded as 1 dependent, okay? And again, go back to that decision tree. Our chair to bed transfer here, that begins with the recipient sitting in a chair or wheelchair, sitting upright at the edge of a bed possibly, returning and sitting to a chair or wheelchair and sitting at the upright at the edge of the bed. So not falling over, okay? Again, that's going to need to be documented, okay? If you use a mechanical lift to assist with the transfer, and 2 helpers are needed to assist with the mechanical lift, coded as 1 dependent, even if the resident assists in any part of that chair to bed to chair transfer. Okay, our toilet transfer here, again, not much, just follow that decision tree and remember to keep code usual performance with this one. Right. Some tips for success. So hopefully MDS teams at your facilities have already long been preparing for this transition. Through trainings, there are many resources available at APAC and CMS. Of course, as I said, as we conduct our trainings, we'll be conducting more, or conduct our reviews, we'll be conducting more significant and detailed trainings on this as we get to review the documentation and understand it better ourselves. Okay. Some other things is just to understand the importance of this functional improvement and how to best facilitate that resident progress. Establish some documentation protocols too would be another big thing. And then practice coding in a variety of scenarios. And then an audit regularly would be something that if I were the MDS coordinator, I would be doing on a regular basis, okay? All right, on to our Nevada supportive documentation guidelines. As I have stated, they will be edited soon by December before our reviews start to include section GG, to remove any sections that are no longer included in the reviews, okay? So in the meantime, you will still be any documentation possibly that we review that is within the dates that we are using the old version, we will be held accountable for. Errors will be recorded for that until they're updated. But as I stated, if it does not include new revised sections of the MDS or it hasn't been added yet, you will not be held accountable for that, or no errors will be recorded. Okay. You can find that on the ltssnursing.nv.gov. That will be posted there as well. Also, a new version will be sent out through the PDPM mailbox to all the MDS coordinators when it's completed. And some things here that probably won't change on the last page of the documentation guidelines. We see this here. It just goes over review procedures. If you haven't done or looked at that and you're new or you have never seen this document before, please familiarize yourself with that, okay? And then the last page of it is something about signature date at Z0400, okay? And this relates to the BIMS and the PHQ-9 interview. So please take a look at that and read that. Some additional resource contacts, of course, Carol, and then of course myself here. If you do not have or not receiving emails from the PDPM mailbox here at Medicaid, please just click on this link and send me an email and I will get you on the list. Please give me what your position is at the facility. Unfortunately, I believe with the stakeholder work groups, we're mostly in the last 2 sessions of that, I believe. And if you want to be a part of that, I'm not sure how helpful that would be for you at this time. But if that's something you would like to do, you can send me that request as well. Okay, I'm going to open it up for questions here.
Sure.
Just a quick question on the annual LPN competency requirement for the state. Would be like an on-the-job annual skills checklist or competency conducted by a certified RAC basically be acceptable by the Board of Nursing?
Well, it's yes. Yes.
Okay.
And by us as well, by the surveyors, by the state.
Awesome. Thank you so much.
You're welcome. Thank you. Mary Parker, go ahead and unmute.
Okay, can you answer the question that Storm had posted on here? You know, because Nevada's not going to be using the OSA, and with the removal of Section G, are we still going to be able to, with the way the item set will be in the system now, are we going to still be able to get that RUG 3, you know, grouper so that starting October 1st, or are we going to be needing to do the OSA along with the quarterlies and annuals to actually get our case mix? Trying to figure out how we're going to work this.
Well,
Okay.
that's the difficult question that I think that we've gotten really close to the wire here, of course. And I'm hoping the facilities, your facility has given you guidance on this at this point with the transition to PDPM. And using that, you don't have systems in place for that, because basically where we're at is that the data is going to start coming in for PDPM, and we don't really have a role in that. Myers and Stauffer takes in the data, right? And then when we do our reviews, we look at that, what was submitted on those submissions by your facilities, and we choose certain items that we're going to review. We try to give you the highest CMI index when we go in and we do our review. So I don't really have an answer for you. I mean, that's something your facility should be guiding you on. Does that make sense, Mary?
Well, yeah, I guess in a way, but probably what we're going to have to do then, I guess, would be to get in touch with Myers and Stauffer to see how if it's going to work on their end, you know, because Nevada, we're still going to need to get that case mix index score in order to receive payment for Medicaid.
And it's my understanding that OSA is very problematic, both for us as well as the providers. Have you been given direction from your facility, Mary, that you're going to be using the OSA? Because I do know there's some talk of that going around the circles. And if you've been a part of we've been having these meetings since February. We've been pretty clear that we're moving towards this process.
Well, and we know that, you know, with Nevada, they're going to the PDPM. I know that, you know, like Wyoming is one of my states also.
Oh,
and
okay.
they are going to be using the OSA. And so we do have the ability that if we need to do it so that we can get that case mix index score for Myers and Stauffer, I mean, we can do it, but if Nevada's going to totally move to the PDPM, which I know everybody is eventually, we're just trying to figure out, do we need to plan on doing it now just until Nevada's fully transitioned over? I guess, I think Myers and Stauffer would be one that we could contact and find out what their take on it is
Yeah,
gonna be.
that may be the best option for you. I'm
Yeah.
sorry. And a lot of these decisions, I want everybody to know, are actually not made by me, of course. I do participate in these meetings, but we're working with the Nevada Healthcare Association, which represents facilities, and as well as many of the representatives from your facilities on this. But as I said, we did have a stall here with some disagreements, but I think the decision's been made at this point. My understanding, the information I have is that we are continuing to move with utilizing PDPM.
Okay, thank you, Chris.
Yes. Carol, is that next question up there? Let's see, Paula, I think.
Yes.
Per Nevada state guidelines, who is qualified to do the BIMs aside from social workers, nurses, clinicians, PT, OT, ST qualified? Thank you. As I was doing my presentation and tidying up this morning, I actually had that question pop in my mind. Carol, do you have a direct answer for that? And I think that's something I'm going to have to discuss with you and find out more information about if you do not.
Okay, can you hear me?
Yes.
My answer at this point in time, I would need to do a little research, but as long as they are trained and know how to do it, I mean, just because they're a PT, OT doesn't necessarily mean they know how to do this interview. But if they train for it, if they read the instructions and follow it, and they get checked off as being competent, then I would say yes, they can.
Okay. We're going to look more at that question, Maria. We'll put that in our notes and get back to you on that, well, to everybody on the meeting, what the answer for that was, okay, in the final decision.
Thank you for your question, Kay. Paula, where's Paula? I can't find her now.
Hi, I'm here.
Okay,
See,
good, thanks.
This is my question real quickly. I had to step out and use the little girls' room, so I hope this is not a duplicate. My question is, when an LPN conducts any kind of assessment on the MDS or anything like that, what is the best way for the state? Can I just document that in the section that they composed? This was reviewed and by me, or put it in like a cost summary sheet, or put it in the section Z4 when I sign it off?
Okay, I think I know what you're asking really is twofold. First of all, was the LPN assigned by the coordinating RN to do that? And Chris and I had this discussion as well. Where would we document that? I think that's going to depend facility to facility where it's documented, but it does need to be, readily seen by the surveyors when they come in. Okay, this LPN did this assessment. Where's the assignment for them to do this?
I see.
So,
well, because it would seem to me that it would be easier to find it in the MDS than have to go through and review all the progress notes.
exactly.
And I'd say we'd accept any of those
Okay.
things
All
that you
right.
said, but yes, it would be easier just to find that there. That's part of what we do is we search through the notes to try to find information. Although now with this remote review process, part of the discussion we've had about that is it's going to make it much easier for us as reviewers, and hopefully for you as a facility, for staff that have to be involved in this process to get us the information that we need. Who knows best, of course, where that information is, the MDS coordinator, whoever put that information there, right? So
Yeah. Okay,
you'll be able to present it to us and just send it to us, and then we can say, check, check, check.
Okay.
Anybody else? Dame is asking, Chris, are they completely rolling to full PDPM July 1st next year in Nevada, or only nursing PDPM component? Is it still up for discussion?
Okay, so currently, what's being discussed is a couple different scenarios, and these are way more complex than I can explain. I'm just going to say it in layman terms. Blended scenarios of where we include possibly some rug data, and then how that's all plays out at different periods and quarters. Okay. And of course, the providers, of course, are interested most in, or not most, but they're interested in reimbursement. What's going to benefit them most with reimbursement? That's one of the big concerns. So we're trying to work with the providers in the group now to determine there's like I said, 3 different scenarios possibly of how that's going to play out. Okay. And so until that's finalized, in the stakeholder work groups, I can't really answer that question other than it could be, we may decide to slowly blend in the rates over the quarters, the next few quarters. It could be just decide we do this at July 2024, or maybe even possibly extend it beyond there. Updates will be provided as soon as we know. And what's going to be really informative is the experts at Myers and Stauffer, once we complete this process with the stakeholders, are going to be doing some trainings for the providers as well, I'm told. Okay. So they're the ones who have done this in other states. They have a very good understanding. They have trainers specifically who have trained other states to do this. So that will be in the very, very near future. And I am sorry for the timeline is leaving you guys like this. As I said at the beginning of the training, I was hoping we would have this definitely done by now, and working on possibly the Nevada documentations being implemented by October 1st as well. But it didn't work out that way, beyond my control.
Okay, next we have Brenda.
Go ahead, Brenda.
Yeah.
Okay. We got an email from the VA about doing an OSA for their patients that we've got when we do their OBRA, because, where is it? So how are we going to do that if OSA is going to be removed?
Brenda, what facility are you representing?
Alta?
Alta. Okay, yeah, I've heard that there's some information going around about that. I could you send that to me to the PDPM mailbox, and I could probably respond to you better by looking at that.
Okay. Thank you.
I can add a comment to the VA question. What we found is, like in South Dakota, for instance, if the VA contract is paying by a rug score, then you do have to do that OSA for some of the contracts. You have to look and see if they're paying a level or if they're paying by the rug score, and then that determines whether you do the OSA. We have a big mess with that with the VA.
Okay,
Yeah, they wanted rugs still for their patients, so.
I'm wondering if the confusion with that is that this has been a topic that's come up in the last year with the VA. We have done reviews on them for some reason in the past, and they are not a facility that we should be reviewing. So in the future, it's my understanding that we will not be reviewing the VA facilities at this point.
Interesting.
So I'm wondering if maybe they have their own guidelines possibly that they're following.
Okay.
But that's probably where that confusion is coming from. We will not be reviewing them.
Asriana, go ahead and ask your question.
Hello, are you able to hear me? Okay.
Yes,
Yes,
but there's
sounds
an
good.
echo.
Sorry about that. I posted my question in the comments, and
Yes.
I'll mute myself back and you can just read the comment.
Okay.
Okay, let me
So
look here.
she asked about section D. You want to read
Oh.
it, Chris?
Yeah,
ahead.
I guess I needed to scroll down on the chat. I'm sorry. For section D, if a staff assessment is needed, a backup clinical documentation needed to support feedback. For instance, patient feeling tired all the time. Is documentation on patient not leaving the room needed, or is staff reporting good enough? Okay.
More the better.
The more the better, yeah. And again, just we look for notes and however, you know, here's what I think all the MDS coordinators need to start thinking about. Now that we are definitively going to go to a remote review process, how can you best present this information to us? What's going to be easiest for you? In the past, we've historically, when we've gone in for reviews, we've had to search through records. You know how the ones who have worked with us before, we work with usually one or two of your MDS team, and we spend quite a bit of time looking through records. The problem with that, of course, being that we aren't familiar with your electronic systems. It takes time for us to learn that. We have to ask for direction usually from you. You will be able to present to us the documents that we're requesting, okay, the information that we're requesting. You know how best to get that to us, as long as you are referring to the MDS as well as the Nevada documentation guidelines. Come up with your procedures for how to correctly document that, so it's not an issue. I mean, I really anticipate with the remote review process that errors should improve quite a bit, really. I mean, we're not going to be looking at, you know, things that are difficult to find. You as MDS coordinators should know where to find those things. Does that answer your question? I hope. If staff assessment is needed, backup clinical documentation. Yes, absolutely. I think so for that. Yeah. Any comments on that, Carol?
I would just say that yes, as much documentation as you can get that explains the situation. It just makes it that much easier for the reviewers to see, okay, this resident is depressed, and how do we know that? Because here's the supportive documentation telling us exactly.
Yeah, I agree.
All right, I want to go back and address something that somebody mentioned earlier, excuse me, regarding the coding of N0415. On the in the RAI manual on page N-6, there's a box off to the side that says indication. The identified documented clinical rationale for administering a medication that is based upon a physician's or prescriber's assessment of the resident's condition and therapeutic goals. So if a patient is receiving a medication, no matter what it is, yes, you're going to code it under the classification, the pharmacological classification. But the second column is asking, is there documentation in the medical record indicating why the resident is being prescribed and is taking this medication? So, post-test question number 1. SNFs may code a UTI as an active diagnosis if McGear, NHSN, or low criteria are met, or if a physician allowed practitioner documented a UTI in the last 30 days. True or false? And the answer is false. You can replace or with and, because the requirement is for both. Okay? But you need the criteria and the allowed practitioners documented UTI in the last 30 days. Number 2, a facility can be cited for chemically restraining a resident who is on an antipsychotic medication if the record lacks documented history of at least one of 5 specific behaviors for at least 6 months. True or false? The answer is true. Number 3, any staff member can document in the MDS if they maintain ongoing and current training and have been deemed competent to do so. True or false? The answer to that one is true. So long as they've been trained, well, and they have to have a license. Like someone else pointed out, no, Chris pointed out, CNAs can't actually document in the MDS, but their information from flow sheets is used, isn't it? So while they're not actually documenting in the MDS, information that they provide might be carried over into the MDS. Okay, number 4. Under the Nevada State Board of Nursing Practice Act, LPNs can pick and choose how they will contribute to the MDS, true or false? The answer is false. An RN must assign the task to the LPN, and that means specific sections. The RN can't say, okay, LPN, go and fill out the MDS. No, they have to assign them the specific sections that they're going to complete. And then, of course, they have to sign off if they did it. Number 5, rehabilitation therapies may include the resident carrying out a prescribed program independently. True or false? And the answer to that one is true. We learned that today. Number 6, restorative nursing programs are included in rehabilitation therapies. True or false? The answer is false. Restorative nursing programs are nursing programs, not therapy programs, and nursing programs do not need a physician order. Number 7, a trial of a mechanically altered diet ordered and provided during the observation period should be coded at K0520C. True or false? The answer for that is false. It should not be coded, and you can see page K-13 coding tips for an explanation about that. And Chris, the next several are yours.
Carol, I don't have a copy of the questions and the slides you
I
sent
sent
me
them to
earlier.
you this morning.
I don't have them. Looking
Oh.
back.
I wonder where they went. Do you want me to just go ahead?
Yeah.
Okay.
The slides you sent me this morning, I don't see them there. Yeah.
I sent it before that. I think last night, actually. Anyway, I know I sent them. Or maybe I didn't. I don't know. Who knows at this point? It's sorry. Number 8. There is no need to update the resident's diagnosis to reflect a current condition because it is not related to the admitting diagnosis. True or false? The answer is false. Diagnoses should be updated to reflect the current condition and treatments a resident is receiving. Number 9, when a resident wants to be alone in a private room, it can be coded as isolation. True or false? The answer is false. Isolation is only coded when the resident requires transmission-based precautions and is placed in isolation due to an active infection. Number 10, an asymptomatic resident with a positive history of C. diff and MRSA can be coded as being on isolation. True or false? The answer is false because the infection is not active. Therefore, isolation would not be coded. It's a history of those. Number 11, to be coded on the MDS, isolation only requires a physician order. True or false? The answer is false. While isolation does require a physician order, it also needs supporting documentation of the need for a private room and documentation supporting the need for the resident to remain in their room and receive services there. They can't leave their room, just like Chris explained. Number 12, when coding section GG0100 prior functioning everyday activities, the resident, the resident's family, and the medical records are all acceptable sources of information. True or false? The answer is true. All 3 sources are acceptable when coding GG0100. And that is the end of the post-test question and answers.
Thank you, everybody. We will see you at the next training and hopefully sometime in the near future. for reviews.
All right, everybody, have a great day and thanks again. Take care.